Welcome to the Deep Dive. We aim to get you well informed, fast. And today, um, we're tackling a big one, the endocrine system. It's pretty intricate, right?
Oh, definitely. Elusive is a good word for it.
Yeah. And for nursing students, getting a handle on assessing it, it's absolutely key. It's like learning to decode the body's signals.
Those really subtle ones, the whispers, like you said.
Exactly. So we're diving deep into Chapter 52 from Lewis's MedSurg, the 12th edition. Specifically, the assessment chapter. Our mission here isn't just to, skim the surface. We want to pull out the really crucial bits,
The nuggets.
help you cut through that dense text, get up to speed quickly, and really nail those assessment skills you need for clinics, for NCLEX, all of it. And we'll use a case study, LM, to kind of guide us through this complex landscape.
Yeah, and that case study approach is perfect because, like you said, the endocrine system, it's tricky. It's a master of disguise. Problems often show up with these really nonspecific symptoms: fatigue, weight changes, mood swings, things you might brush off.
Right. Sounds like everyday life sometimes, doesn't it?
Exactly. So that thorough systematic assessment, it's not just important, it's critical for connecting this dot. So yeah, we'll break down the fundamentals, structures, functions, how hormones are controlled, which is fascinating in itself.
Right.
And then walk through the essential subjective, objective data, the diagnostic tests, and the nursing piece that ties it all together. And we'll keep circling back to LM.
Okay, let's start with the basics then. The endocrine system's grand orchestrators. These tiny glands scatter around.
Right, like little factories. The main ones your text points out, like in Fig 52.1, are the hypothalamus and pituitary up in the brain.
The command center.
Yeah, then thyroid and parathyroids in the neck, adrenals on the kidneys, pancreas, ovaries, testes. They're all over.
And their location hints at their wide reach, right?
Absolutely. And collectively, they handle 5 huge jobs. They're vital for fetal development, like the reproductive and nervous systems. They stimulate growth as we mature, manage sexual reproduction, keep everything in balance, that whole homeostasis thing,
Crucial.
and orchestrate how we respond to emergencies, like stress, big jobs.
So these hormones, what exactly are they? Chemical messengers.
Pretty much. Chemical messengers made by these glands that travel, usually through the blood, to target cells or organs and tell them what to do. Think of thyroxine from the thyroid. It goes everywhere, affects almost all tissues.
Okay.
But some hormones act locally, right where they're made, like certain sex steroids in the ovary. That's called paracrine action. Doesn't even hit the main bloodstream.
Interesting. And what makes these hormones work so effectively?
Well, there are a few key things.
Huh.
First, they're potent, secreted in tiny amounts but have big effects.
Like really tiny.
Incredibly small amounts. Second, they're tightly regulated, mostly by feedback loops. We'll get into that. And third, they're specific, like a lock and key, as figure 52.2 shows. A hormone only fits its specific receptor on the target cell.
Lock and key. Got it.
And knowing if they're lipid-soluble or water-soluble helps too. Lipid-soluble ones, like steroids and thyroid hormone, can slip right through cell membranes. They usually need a protein taxi in the blood, though.
Okay. Because they don't like water.
Exactly. Water-soluble ones, like insulin or growth hormone, can't get through the cell membrane easily. They circulate freely in the blood, but have to bind to receptors on the cell surface to pass their message along. Figure 52.3 illustrates that difference.
Right. That distinction matters for how they act. So how does the body control them? You mentioned feedback loops.
Yeah, regulation is key. The most common type is negative feedback. It's like a thermostat.
Okay.
Take calcium and PTH, parathyroid hormone. If your blood calcium gets too low, the parathyroid glands release PTH. PTH works to raise your calcium levels. Once the calcium level comes back up to normal, that higher level tells the parathyroid glands to stop releasing PTH.
Ah, so the result turns off the signal. Simple but effective, like figure 52.4 shows.
Exactly. Self-regulating. There's also positive feedback, less common. Here, the hormone's effect actually triggers more hormone release. It needs something external to stop it. Think oxytocin during labor contractions.
Right, keeps building.
Then there's direct nervous system control, stress, for example.
Yeah.
Your sympathetic nervous system kicks in and tells the adrenal glands, release catecholamines, now. Epinephrine, norepinephrine, the fight or flight stuff.
Instant response.
Yeah. And finally, physiologic rhythms. This is super important for nurses interpreting labs.
Okay, tell me more.
The big one is circadian rhythm, the 24-hour cycle. Cortisol is a classic example. Levels are naturally high in the early morning and drop off in the evening. Figure 52.5 shows that pattern clearly.
So drawing a cortisol level at 4 p.m. gives you a totally different picture than one at 8 a.m.
Absolutely. And other hormones like growth hormone, TSH, prolactin peak during sleep. Then you have longer cycles too, like the menstrual cycle, ultradian rhythms.
So the timing of blood draws or urine collections is critical. You
Yeah.
can't just grab a sample anytime.
Exactly. You might miss the problem or get a misleading result. Huge point for practice.
Okay, let's zoom in on some specific glands. Starting at the top, the hypothalamus,
Mm,
the master's master.
you got it. It sends signals, releasing and inhibiting hormones down to the pituitary. Table 52.2 lists them things like TRH to stimulate TSH release or somatostatin to block growth hormone. It's pulling the strings.
And the pituitary, the hypophysis, tucked away there in the cella turcica, right? Connected to the hypothalamus.
Yeah, connected by that stalk, as you see in figure 52.1. It has two main parts. The anterior pituitary, the adenohypophysis, gets its orders from the hypothalamus via a special portal blood system. It then releases tropic hormones that tell other endocrine glands what to do.
Like TSH for the thyroid?
Exactly. TSH, ACTH for the adrenals, FSH and LH for the gonads, plus growth hormone, prolactin. Table 52.1 gives a good rundown of their targets and jobs.
And the posterior pituitary, neurohypophysis.
That's more like a storage shed. It doesn't make hormones itself. It stores and releases two hormones made in the hypothalamus, ADH and oxytocin.
ADH antidiuretic hormone. That sounds important for fluid balance.
Hugely important. Its main job, shown in figure 52.7, is to tell your kidneys to reabsorb water, so it helps regulate your body's fluid volume and concentration.
Because your blood gets too concentrated.
ADH gets released, you reabsorb more water, urine gets concentrated, and hopefully your blood osmolarity goes back to normal. It's crucial in things like dehydration or conditions like SIADH or diabetes insipidus.
Okay, what about the pineal gland, also in the brain?
Yep, tiny little thing. Secretes melatonin, mostly known for regulating sleep-wake cycles, the circadian rhythms, but also plays a role in puberty onset.
Got it. Now down to the neck, the thyroid. That butterfly shape in figure 52.8.
Right. Its main job is making T4 thyroxine and T3 triiodothyronine. These guys regulate your metabolism, basically how fast your cells work, plus growth and development.
And you need iodine for those, right?
Absolutely essential. No iodine, no T3 or T4. The thyroid also makes calcitonin.
Calcitonin. That sounds like calcium.
It is. Calcitonin lowers blood calcium. It encourages calcium storage in bone and tells the kidneys to excrete more calcium. It opposes the action of another hormone,
That could be.
parathyroid hormone, or PTH, made by the parathyroid glands, usually four tiny glands tucked behind the thyroid, also shown in figure 52.8. PTH does the opposite of calcitonin. It raises blood calcium.
How does it do that?
It pulls calcium out of bones, tells the kidneys to keep more calcium, and helps activate vitamin D so you can absorb more calcium from your food.
So PTH up when calcium is low, calcitonin up when calcium is high. Kind of.
PTH regulation is tightly linked to calcium via negative feedback. Calcitonin's role in humans is a bit less critical day-to-day compared to PTH, but yeah, they have opposing effects on calcium.
Okay. Moving down to the adrenal glands. On top of the kidneys, figure 52.9 shows them. Two parts here, too.
Yep. The inner part is the adrenal medulla. That's your fight or flight center, pumping out catecholamines, epinephrine, norepinephrine, adrenaline rush central.
Got it. And the outer part, the cortex.
The adrenal cortex. This part makes steroid hormones, all derived from cholesterol. Three main types.
Okay, what are they?
First, glucocorticoids. Cortisol is the main one. Absolutely essential for life. Regulates blood glucose, suppresses inflammation, helps maintain blood pressure. A real workhorse. And remember that diurnal rhythm, high in the AM, low in the PM.
Right. Crucial for testing. What else?
Mineralocorticoids. Aldosterone is the big one here. Its main job is managing fluid and electrolyte balance, particularly sodium and potassium. It tells the kidneys to hold on to sodium in water and get rid of potassium.
So it affects blood pressure, too.
Definitely. And third, small amounts of adrenal androgens. These are precursors that can be converted to sex hormones like testosterone or estrogen elsewhere in the body.
Okay, adrenals covered. What about the pancreas? I know it does digestion stuff.
It does. That's its exocrine function. But it has a crucial endocrine function, too, located in the islets of Langerhans, little clusters of cells.
And they make...
Two key hormones for blood sugar control. Alpha cells make glucagon. Glucagon raises blood glucose. If your sugar drops too low, glucagon tells your liver to release stored glucose.
Okay, raises sugar. And the other one.
Beta cells make insulin. Insulin does the opposite. It lowers blood glucose by helping glucose get into your cells to be used for energy or stored. It's the main regulator of carbohydrate, fat, and protein metabolism.
So insulin lowers sugar, glucagon raises it, They work together to keep blood glucose stable.
Exactly. A constant balancing act. And understanding that dance is fundamental to understanding diabetes.
Now, things change as we get older. What are some key gerontologic considerations? Table 52.3 mentions some things.
Yeah, aging brings changes. Generally, you might see decreased hormone production or secretion. The body might not respond as well to the hormones that are there. Hormone metabolism can slow down, and even those circadian rhythms can shift.
And clinically, why is that important for nurses?
It's critical because endocrine disorders in older adults can be really insidious. The symptoms, fatigue, constipation, maybe some confusion, can easily be mistaken for just getting older.
Or blamed on other chronic conditions or medications they're taking.
Exactly. So problems often get missed or diagnosed late. You need a high index of suspicion and really sharp assessment skills with older patients.
Which brings us right to the core. Assessment. The nurse's detective work. And like we said, endocrine issues often creep up slowly with vague symptoms.
Very vague sometimes, which is why the subjective data, the patient interview, is so incredibly important. Let's bring back LM. Remember her? 35 years old, just not feeling well, weight gain, tired all the time.
Classic vague start.
Right. So using the framework from table 52.4, the functional health patterns, we'd start digging. Any past health history of endocrine issues? Family history, diabetes, thyroid problems. Box 52.1 flags genetic risks.
Okay.
Then nutritional metabolic, that weight gain, where is it? All over or specific places. Appetite changes, nausea, trouble swallowing. Ask about heat or cold intolerance, nervousness, palpitations, sweating, those SNS overdrive signs. Skin changes, hair changes, easy bruising.
Lots to ask there.
Yep. Elimination. Increased thirst or urination, diabetes red flags, changes in bowel habits, constipation or diarrhea can point to thyroid issues.
What about her fatigue?
That hits activity, exercise, and sleep rest. How's her energy level really? Sleeping okay? Waking up at night?
Cognitive perceptual.
Memory issues.
Vision changes. Ella mentioned blurry vision later.
Good point. Pituitary tumors can press on optic nerves. Self-perception. How does she feel about the changes? Body image impact. Sexuality, reproductive. Menstrual changes. Hair growth where it shouldn't be, infertility history, history of big babies, coping stress, how's she handling stress? Stress can really exacerbate things like adrenal insufficiency.
Okay, so for LM, after that detailed interview, the picture got clear. She added chronic headaches, severe fatigue, irritability, that blurry vision. Plus, the weight gain was mostly abdominal. She noticed facial hair bruised easily, and her scalp hair was thinning. That's way beyond just not feeling well.
Absolutely. Those are the red flags popping up from the subjective data. Huge clues pointing towards something specific going on.
So subjective clues gathered. Now the objective data, the physical exam, since we can't really poke most endocrine glands.
We look at their effects on the body. Start general. Orientation, alertness, mood. Vital signs looking for patterns or changes in BP, heart rate, temp, height, weight, BMI.
Then integumentary skin. Color changes, like that bronzing in Addison's disease. Texture, moisture, hair distribution loss, excess, bruising, wound healing.
Head, neck, facial symmetry, any puffiness. Check visual fields carefully. Check for exophthalmos, those bulging eyes and hyperthyroidism. Then the thyroid exam.
Right, inspection and palpation.
Inspect as they swallow, the thyroid moves up. Then palpation, usually from behind, as shown in figure 52.0. Gentle pressure, feel each lobe as they swallow again, looking for size, shape, nodules, consistency.
And the big caution.
Don't palpate vigorously if it feels enlarged. You could trigger a hormone surge, a thyroid storm. Be gentle. If it's enlarged, auscultate over it for a bruit. That swishing sound indicates increased blood flow, common in hyperthyroidism.
Okay. Thorax.
Look for gynecomastia in men. Listen to heart and lung signs of fluid overload like crackles could point to SIADH or hypothyroidism.
Abdomen.
Contour, truncal obesity. And look closely for striae stretch marks. Are they silvery white or that distinctive purple-blue seen in Cushing syndrome?
Extremities.
Size of hands and feet, large ones suggest acromegaly. Skin changes, edema, muscle strength. Check deep tendon reflexes. Hyperreflexia can occur in hyperthyroidism. Tremors.
Let's connect this back to LM's physical findings. She was anxious. BP was way up at 1980, weight 160, height 5'4", reddened, puffy face, that buffalo hump on her upper back, acne, facial hair, protruding abdomen but thin arms and legs, ankle edema, bruises, and those purple abdominal stretch marks.
Okay, so when you see that cluster of findings, the central obesity, thin extremities, moon face, buffalo hump, purple striae, hypertension, easy bruising, hirsutism, you should immediately think Cushing syndrome. Table 52.5 lists these abnormalities. Her presentation is almost textbook.
The physical exam really solidified the suspicion here.
Absolutely. It turned those vague, subjective complaints into a much clearer clinical picture pointing towards excess cortisol.
So history and physical point strongly in one direction. Next step, diagnostics to confirm.
Right. And the choice of tests depends entirely on what you suspect from the H&P. Imaging like CT or MRI can find tumors. MRI is great for pituitary issues. Thyroid scans, RAIU, radioactive iodine uptake, look at thyroid function and structure. Lab studies are key. Measuring hormone levels directly or indirect markers like glucose, calcium, electrolytes.
I'm remembering that timing issue.
Critical. Single random samples might not cut it. You often need 24-hour urine collections or tests done at specific times a day, like morning cortisol, or dynamic test suppression or stimulation tests to see how the system responds.
For nursing students, what are the must-know tests? Tables 52.6 and 52.7 have a lot.
Okay, key ones. Thyroid. TSH is usually the first test. Very sensitive. Free T4 is often measured too. It's more accurate than total T4, sometimes T3. Antibodies if autoimmune disease is suspected.
Parathyroid.
PTH levels, serum calcium, total and ionized, and phosphate. They work together. Cortisol serum in urine, often checking the diurnal rhythm or doing suppression tests like with dexamethasone or stimulation tests with ACTH. Aldosterone. For pheochromocytoma, checking metanephrines in urine or plasma.
Pancreas. Mostly diabetes related.
Yep. Fasting blood glucose, FBG. A1C, glycosylated hemoglobin for long-term control. Glucose tolerance test, GTT, maybe C-peptide or insulin levels.
And pituitary.
Depends what you suspect.
Right.
ADH levels, often with water deprivation tests for DI or SIADH. GH levels, often via IGF-1. FSH, LH for reproductive issues. Now, back to LM. Her initial labs, drawn fasting. CBC showed high WBCs, low lymphocytes. FBG was 130 mg/L elevated, and the kicker, high plasma cortisol and high plasma ACTH. Her thyroid tests were normal.
Okay, break that down. High cortisol explains many of her symptoms, right? The weight gain, bruising, high BP, high glucose.
Exactly. The high FBG fits, cortisol raises blood sugar. The high WBCs and low lymphocytes are also typical effects of excess cortisol.
But the ACTH is high too. What does that tell us?
That's the crucial piece. If the problem was just the adrenal gland overproducing cortisol on its own, like an adrenal tumor, you'd expect ACTH to be low because of negative feedback from the high cortisol telling the pituitary to shut down.
Oh, okay.
But here, both cortisol and ACTH are high. This points the finger squarely at the pituitary gland overproducing ACTH, which then overstimulates the adrenal glands to pump out cortisol. That specific pattern is called Cushing disease.
Wow. So the labs combined with the H&P really pinpoint the underlying cause.
Precisely. It's a fantastic example of putting all the assessment pieces together.
Well, that was quite a journey through the endocrine system, from the basics, the glands, the hormones, the complex regulation, all the way to the detailed assessment, subjective, objective, and those critical diagnostic tests using LM to illustrate it all. It really shows how much detective work is involved.
It really does. And for everyone listening, remember that understanding the why behind each step, why ask that question, why look for that sign, why is that lab value significant, that's what elevates your nursing practice. It's about seeing the whole person and connecting those often subtle dots.
Absolutely. So here's a final thought for you. We've seen how profound endocrine changes can start with really unassuming symptoms. Thinking about LM's initial just not feeling well. How can honing your understanding of these subtle shifts, these whispers from the body, make you a more intuitive, more effective nurse? How can it empower you to really connect those dots for your patients sooner and potentially change their outcomes? Something to think about. Thanks for diving deep with us today.